Hi, everybody. I'm Adam Hoffberg, and I'm joined today by Dr. Katie Lewis with the Austen Riggs Center, and she's going to talk to us today at the American Association of Suicidology Conference about some of the research that she's doing over at the Austen Riggs Center. So welcome, Katie.
Thank you so much for having me, Adam.
Great. It's a pleasure to have you as well. So just jumping in to tell us a little bit about yourself and the center you work out and why you're interested in this work.
Sure. So my current role is as the Research Psychologist at the Austen Riggs Center. Riggs is a small residential psychiatric treatment facility in Western Massachusetts that specializes in treating adult patients who experience chronic complex psychopathology. So typically patients come to the Austen Riggs Center after they've already had multiple trials of different psychotherapy or medication management regimens and have just found that treatment hasn't been working to really address their underlying concerns and underlying issues. So they come to our hospital and they receive intensive psychodynamically oriented treatment. They see their therapist 4 times a week. They have comprehensive psychopharm services, social work services, and nursing support. And they complete a 6-week intensive evaluation period during which they get, sort of oriented to treatment. They begin working with their therapist. They get comprehensive psychological testing at that point. And at the end of the 6 weeks of this initial evaluation period, it sort of culminates in this case conference where diagnostic decisions are made and sort of treatment recommendations are formulated. And patients at that point either choose to leave to go to a different treatment facility, if that's the decision that they sort of reached with their therapist, or they remain in treatment at the center. And I think our average length of stay at this point for patients is somewhere between 6 to 8 months. So often they will be staying and will continue to just sort of do this deep dive into working on their mental health issues that they really haven't had an opportunity to work at in the same way in their previous treatments. And sometimes they can stay as long as a year or two. Sometimes it's a shorter length of stay. But we really do get to know patients as they stay in our treatment facility. And because of that, it's a really wonderful place to do research. There's not sort of a rush to do a brief evaluation. We can do more longitudinal studies or studies that really can get more into the complexity of patients' experiences. So my role as the research psychologist is to help them grow and develop their suicide research and prevention program. And the main study we have going right now is an ecological momentary assessment that's looking at how daily interpersonal experiences of patients at the center are related to momentary fluctuations in their suicidal ideation. Most patients are coming into the center with, a history of at least suicidal ideation. I think around half have a history of multiple suicide attempts. So suicidality is a really common clinical concern with patients at our hospital. And what we're trying to do is really understand how interpersonal dynamics and interpersonal functioning serve as either protective factors against this sort of ongoing suicidality that they're contending with, or as risk factors. And we know from past research that interpersonal relationships can function both as protective factors or as risk factors for suicide. But to my knowledge, this hasn't really been looked at on a momentary level. There's been some research to show that things like arguments can trigger suicidal ideation or suicidal impulses, but the sort of day-to-day experiences and reasons for why those particular events might be triggering hasn't really been looked at in depth. So that's my main study right now in the work that I'm doing.
Very fascinating, and I think we're going to go into that with a little bit more detail because it's very interesting work. Just to give some of the fundamentals, though, to folks who may not know what ecological momentary assessment is, or just the idea of assessing very often, and how do you do that?
The way specifically that we do it in our study is we have participants complete interpersonal ratings using an app on their smartphone. So they do get reminders, but basically to do the ratings, when they sign up for the study, they might say, can you remind me at like lunch and dinner that I should be doing this study, which is helpful. There are other approaches that where participants would actually do ratings after getting prompts to do the ratings, but we like to leave it a little bit more open and let patients who are in our study decide when they're doing the ratings, since we're basing them on interpersonal events and those are hard to predict. So we're using an app for our study specifically that sends reminders, but basically that participants can open, and it's about 2 minutes worth of really quick questions. Some of the questions that they're completing are on sort of like slider scales, like how anxious were you during this interaction, and they can sort of select how anxious they felt. And others might be multiple choice questions like, did you experience any thoughts of doing the following during this interaction? And one of the options might be, suicide, but we also ask about impulses to drink, impulses to break something, impulses to isolate. So we're trying to sample a range of experiences that people might have in response to interpersonal stress. But there are lots of ways that other researchers have approached ecological momentary assessment, which really just means sampling experiences over the course of time to get a sense of how people might be behaving or thinking about their experiences over time in real time, without sort of the distortion that can happen from self-report or retrospective reports.
Absolutely, and you just kind of touched on that, but go into that a little bit more, why it's important to get these responses sort of in the moment or as it's happening, and why does that, especially around suicide and suicide prevention, why is that important?
Well, of course, suicidal ideation can fluctuate very widely, and because it can often happen during periods when people are particularly affectively distressed or during high periods of just stress in general, it might be difficult to retrospectively do a really clear report of how intense a suicidal thought was, particularly if it's a more subtle kind of urge that flares up in the moment. People might kind of disregard it and forget about it afterwards. But these moments might be really important if you think about how they accumulate over time, or how they might signal the salience of a particular interpersonal dynamic for being a triggering event. So it is important to capture in real time to get a clear understanding just of how variable these impulses are over time. And I put as much weight also on the report of the interpersonal experiences too, because I think people often have an image of how they tend to behave in their relationships that might not always correspond to how they are actually behaving in their relationships. And the same with how they perceive other people as acting towards them. There's a lot of revision that can happen as we look back over our day, even over the course of a couple of hours. So to be able to capture it in the moment, I think is really valuable and an important new approach that many people have been taking in the field of suicide research, and we're hoping to be able to be a part of that also.
Very cool. Yeah, it's kind of a really novel that you guys are able to use an app built into their smartphone. Is this a special app you've all developed?
No. This is we have gone through a company called Life Data. I know there are a number of companies that are offering sort of similar platforms. We started out by using which involved sending participants an email link that they had to access, and that was very cumbersome and nobody liked it. So we switched over to more of an app-based platform, and it's worked out really well.
Very cool. So I understand this is a longitudinal study, so you're still collecting data, but what do you hope to find with this type of study? What are some of your hopes around what your results will be, and how can you then apply that for effective intervention and prevention?
Sure. Well, the first part of our study actually involves a really comprehensive personality and interpersonal experiences assessment. So we give participants different questionnaires that are related to this circumplex model of personality, which I won't get into, but it's basically a model of personality that tries to chart things like the kinds of interpersonal problems that people have been having, or their sensitivities to behaviors in others along the dimensions of agency and communion. So to find out basically how people see themselves in terms of their leadership qualities or their affiliation approaches, or their if they tend to describe themselves as having problems with being kind of aloof or distant from people. So we really map out how people describe themselves as functioning along these dimensions. And we also include some other assessments, like we have a facial emotion recognition task, just kind of assuming that if people are having difficulty interpreting the emotional cues of others in their daily life, that probably is going to have an impact on their ability to form meaningful connections with other people, or to use other people to kind of help themselves self-regulate. We start out with that really comprehensive assessment to just get an idea of how people are viewing themselves and where we would expect their interpersonal challenges to come up in daily life. And then we use this to sort of compare to, over the course of a 2-week period, as the participants are doing these daily ratings, to really look at when they do seem to be having more stress in interpersonal situations, or when they do seem to be having suicidal ideation triggered. And my hope is that we'll be able to get a sense of probably a few personality profiles that will come up where, for example, we might find, this sort of an obvious hypothesis, but one idea might be that people who describe themselves at baseline as being pretty desiring of closeness with others and valuing the ability to be open and to connect with others, that these individuals might be much more susceptible to having suicidal ideation be triggered if they feel like during interactions, their interaction partner is being very aloof or acting in some sort of other way, like having, just seeming to be more affectively cold or distant during interactions. And I don't think that'll be the case for everybody. I think there might be people with other profiles who might be more sensitive to things like shame or ridicule, who will describe themselves as being triggered by other kinds of interpersonal dynamics. So that's sort of our hypothesis. And if we are able to find these profiles and describe them, I'm also a clinician, so I picture that my work with suicidal patients, having an understanding of that would be very useful for me. I'd be able to take sort of baseline understanding of patients' personality functioning and their interpersonal history, and use that to begin forming some predictions about the types of situations that might get them into trouble. And hopefully these will generalize across scenarios. So something like there's somebody that seems particularly sensitive to or triggered by being controlled by other people. That could come up in family contexts, that could come up in work contexts, and it's something that sort of cuts across the more specific context of interactions to get more at the sort of interpersonal climate.
So whenever we use new technologies or sort of implement new approaches towards suicide prevention, sometimes there's hesitancy both among clinicians but also from IRB or regulatory review boards. Tell us a little bit about your experience working through that and what you've found so far.
Sure. So the Austen Riggs Center, there are many things I love about it, but one thing that it's sort of known for is that it has this approach to treatment and approach to working with patients that has been very resistant to introducing, new technologies or things that might interfere with just the basic interpersonal engagement and depth of insight-oriented work that occurs at the center. And so because of that, when I started in this position and came in and said, hey, I want everybody to be on their smartphones for 14 days to be in my study, the clinical staff had some concerns. The IRB had some concerns. So I ended up having to really provide a lot of education and background information on how people had used this technology in other clinical settings, and do just a lot of staff education and staff presentation events to just introduce everybody just to the basic technology and the reasons for why I thought this would be an important kind of study for us to do at the hospital. And they had a number of concerns that have been raised in the literature before. Like they were worried if you're asking people, 3 or 4 times a day if they are thinking of suicide, is that going to trigger suicidal ideation in somebody that wouldn't otherwise be thinking of it? And fortunately, I didn't have to answer that question myself. There's been previous studies looking at this exact question to know that just asking doesn't seem to increase the risk. And in fact, it can often decrease the risk because people are, having an outlet to be able to report on it and feel like they're engaged with somebody about it. But they had other more subtle concerns that were difficult to address, clinical staff were worried that patients participating in the study might split treatment in some way, like they might find it easier to report certain things either to me or through an app that they might not necessarily have brought to treatment and might not be working on actively with their therapist. So we ended up having to do a pilot study where we really tried to, we had the basic structure of the study, but we complemented it with feedback form that participants completed, and more often than not, they also asked to meet with me afterwards. So it ended up involving both, a feedback form that they filled out, and then also some just more informal interviews that we did, talking about, for example, whether they felt like participating in the study made them more or less likely to interact with other people. We could see that it could go both ways. It could make people sort of more interpersonally focused during the 2-week period, or because they knew they would have to be rating interactions, they might just kind of back away and not want to interact with other people. We asked them if they had brought up their participation with their therapist, because on the research end, we have, the confidentiality piece to this where we don't tell their therapist that their patient is participating. So we asked them if they had voluntarily brought it up during treatment, and just in general tried to solicit feedback, even from non-participants in the patient community. At the end of the pilot study, we came back and just said, this study has been going on for 2 months. Has anybody noticed? Does anybody have feedback? Does anyone have concerns? And we also did that with the clinical staff at the end of the pilot study. And fortunately, nobody felt like the study had really any impact. The patients that participated said that they didn't feel like it particularly changed their behavior with other patients in the hospital. Many of them said they couldn't remember if they brought it up with their therapist, which I thought was kind of funny. And they in general did talk about finding the study pretty meaningful, and they gave us some great feedback about what could increase the meaning of their participation for them. For example, they said if they could get even just a brief summary report of their ratings over the 2-week period as sort of a summary at the end, that they would find that more meaningful than the gift certificates we were offering them. So we actually added that in, and we're doing that now. We give every participant a summary report at the end of their participation. So it was really valuable, and clinical staff didn't notice an impact. In fact, they were surprised that the pilot study had gone on and they really hadn't noticed, and the patient community also didn't really have any concerns. So in some ways it was sort of a no news is good news feedback. I think that the concerns the clinical staff brought up are really interesting, and I'm not sure just because we didn't find that it was having any impact on patients that means it isn't having any impact. I think that all of us would kind of like to leave that as an open question and not assume it's a negative impact, but just to sort of wonder about, I know there are more interventions coming out now for suicidality that are focused on sort of mindfulness or app-based reporting of suicidal ideation. So in some ways, it's hard to picture this not having some sort of impact on the people who are participating. But right now, we haven't found a clear way of studying it that would really tell us the information, that particular information. But it certainly doesn't seem to be having any sort of disruptive or adverse effects, which I think was the main concern.
Yeah, thanks. And it's very important, and I'm glad you worked through some of those barriers. And I feel like, that's been emerging as a theme at this year's AAS, is that folks are really trying to push boundaries, try new things, try new applications, new techniques. So it's great to hear about this work. Any final thoughts before we let you go, Katie?
No, I'm very grateful that you guys are doing this sort of podcast, and this conference has just been, it's been really wonderful because I hear people presenting on this sort of tension between doing, sort of a theory-based, very focused assessment of suicide risk, but also introducing more complex factors and more unknowns into, the types of things that could influence suicidality in different individuals. And I'm kind of encouraged, feeling like the study that we're doing is at least fitting into that conversation in a way. And it's been really great hearing the presenters here, and then, taking that as inspiration to keep doing the work that we're doing. And it's nice to have a place to sort of pull my thoughts together with this podcast. So
fantastic. And how can folks go to learn more about your work or your center, and if they want to reach out to you with any follow-up questions?
Sure, we do. We have a website for the Austen Riggs Center. It's austenriggs.net, and Austen is spelled AUSTENRIGGS.net. And my email address for anybody that might be interested in learning more about the study or just getting in touch is katie.lewis@austenriggs.net. So I'd be really happy to hear from people, and always interested in feedback about the work we're doing, or happy to answer questions anytime.
Excellent, and we'll definitely include links on that with the notes from this podcast so folks can really get in touch with you easily.
Thank you.
Well, thanks for being here.
Thanks so much.
Great.